So good afternoon, one and all. So today webinar session. So resource person is Ms. Divya Rani, Associate Professor, Bulawayo University, Ethiopia. And topic is global impact of COVID-19 on maternity care practice and childbearing expense. So welcome you, ma'am, for.
Hello, can you hear me? Hello.
Yes, madam, completely.
Can you hear me?
Completely, you are completely audible.
Can you hear me? Okay, shall I start?
Please,
Shall
madam.
I start?
Please, madam.
Okay. Thank you, Dr. Sanjay, for the introduction, and thank you, Parul College of Nursing, for the opportunity you have given me to share few information, which is a hot topic today during the time of COVID-19, that is maternity care practices. What is the impact of COVID-19 on these practices? So shall we go to the condition, that is, as you all know, coronavirus has started infecting the world in the late 2019, and as a result of this, World Health Organization has declared this as a major global pandemic on March 11, 2020. Since then, every part of the world has been struggling to overcome this disease, and even today many of the countries are going through second and third wave of infection, and even governments are taking different adaptive measures to overcome this disease and even to prevent the spread of infection. And you can see that even the healthcare providers are also struggling with their limited resources to give service to the people. And at this particular COVID-19 pandemic situation, because the health facilities were giving more importance to the COVID-19 patient, what happened is that the child bearers, that is the women who were pregnant, they were struggling to get access to these services. So regarding that, we will go into deeper so that you will come to know what is the situation right now in the world. So first, with incidence of COVID-19, as you can see globally, as of October 7th, 2021, as report given by WHO, currently we have around 236 million people have been suffering with COVID-19, and around 4 million people around are suffering death due to this disease. And if you see, throughout the world, around 221 countries and their territories have been affected with COVID-19. And if you see the Indian condition, currently there are around 33 million people of confirmed cases of COVID-19. And if you see the death rate, it is around 449,000 deaths are taken place throughout the world. And if you see the statistics, I have given on the screen that around daily new confirmed cases of India, it shows that there was a peak incidence during the time of September as well as March, April. And this particular statistic shows the daily cases, what is taking place in India. And these particular daily confirmed cases also have some limitations, because as you can see that there was only limited testing was taking place. So this we cannot consider it as an actual case. If you see the actual case, it goes against further high. And if you see the statistics on maternal health, that is how it has impacted on the mother or the woman during the time of pandemic, you can see that the death rate has increased up to 37%. This was a study which was taken in India and Mexico, and it shows that around 37% increase was there. And another study which was done in 17 countries, around 40 studies they have taken, and it shows that there was 27% drop in pregnant women receiving 4 or more antenatal checkup. And if you see the institutional deliveries, there was also a decrease in the institutional deliveries up to 28%, and even prenatal services also reduced to 22%. And as you can see, from the beginning, there was only limited research was conducted regarding the impact of COVID-19 on maternal and newborn health. But as from 2019 up to 2021, if you see, around many research has been taken place in order to identify what exactly, how it is going to affect the mother. So I'll give just a few information which I have collected from different studies which was taken place in different part of the world, which shows how it has impacted the different stages of pregnancy, labor, and even after delivery, how it has affected. And if you see, if a pregnant woman is being infected with the COVID-19, there is more chance for ICU admission, intubation, mechanical ventilation, and death. This was a study which was done in USA. And even some of the common condition which was seen during pregnancy was preterm delivery, low birth weight, cesarean section. All these, the cases has become common among pregnant women who were COVID positive. And if you see the obstetric complications, stillbirth, miscarriage, preeclampsia, fetal growth restriction, coagulopathy, and premature rupture of membrane also were very rare. And even ruptured ectopic pregnancy, maternal depression were also increased during the time of pregnancy. And there was also some of the studies which was done to identify whether placental infection was taking place with the virus, and identified that if the woman develops placental infection, either the symptoms were very mild and or they were asymptomatic. And if the woman is suffering with some pre-existing medical condition, and if she is getting infected with COVID-19, then there is more chance that she can go into some complications of COVID-19. And even the risk of venous thromboembolism was also increased during the time of pregnancy. And if you see the intrauterine transmission of infection, there was a study which was done in Wuhan, China. They have identified that placental infection with the virus, there is possibility was there, but it was not identified as per the data. And even if a positive PCR test which was done immediately after birth also came out positive, but they were not sure whether the infection has taken place in the uterus or it has taken place after the uterus. So in order to confirm whether the actual vertical transmission is taking place, what they did is COVID-19 antibody testing was done on the neonatal blood, and this showed that there was some kind of transmission was taking place, but the instance was very, very low, only 1%. And during the time of labor and delivery, there was a peculiar pattern was identified regarding cesarean section. That is, cesarean section rates were increased in developed countries because of more aggressive management of labor and delivery. More aggressive management means during the time of delivery, the woman, most of the time, because of COVID-19, there was supportive person was not allowed inside the labor room, and the woman was left alone to get delivered. So because of all these things, anxiety increased in the woman, that has contributed to cesarean section. At the same time, in low and middle income countries, cesarean section rates were reduced. This was because of the indirect impact of COVID-19. As we all know, they have limited resources. Even transportation facilities were difficult. So because of that, what happens, they were preferring home deliveries. Maybe that one is the reason why cesarean section has reduced in low and middle income people. And even so, because of all these reasons, in American College of Obstetrics and Gynecology, they gave some recommendation during that time. That is, no visitors, or if visitors are allowed, only one asymptomatic support person was allowed. And immediately expedited discharge was after delivery was conducted. That means immediately after delivery, the woman was sent home. Even if she develops any postpartum complications also, they were reluctant to give service for the woman. So that was a situation when initially the outbreak has taken place. So when, because the no visitors, as I already told you, were not allowed, automatically the cesarean section delivery was increased. And also the woman showed dissatisfaction with the service or the experience what they had with the delivery time. And also because of the expedited discharge, the postpartum death also were increased. And if you see the breastfeeding and infant contact, there was the transmission of the virus through the breast milk was very, very unlikely. And when they did the sample test, that is breast milk test was done, they have identified IgG and IgA antibodies for COVID-19. This indicates that this particular infection can provide some kind of protection to the baby during the time if the woman is getting infected. So, and initially, even though this breastfeeding, roaming in, skin to skin contact, kangaroo care, everything was forbidden, but as the days passed, when they came to know the benefits of breastfeeding, what the WHO and UNICEF has done is they recommended continuing the breastfeeding, rooming in, skin to skin contact with utilizing infection control practices. That is, even if the woman is having some minor symptoms, she can wear the mask as well as and then she can give the care to the baby. Then regarding the mental health, and as you can see in mental health, there was some studies which was done in India, China and Italy. This was done in the intrapartum and postpartum period, and they have identified that the woman during the time of COVID-19, there is more anxiety and depression was identified in the pregnant woman, and the thought of self-harm also were increased. So what were the causes for this? Maternal fear, that is, they had a fear that they may transmit the infection to their babies. And at the time of COVID-19, there was limited availability of antenatal care resources, care, and even social support, social distancing, quarantine procedures, and limited health resources was available. And because of difficulty in transportation, the woman has to deliver at home with limited without trained obstetric clinician. All this contributed to the increase in anxiety in the woman. And if you go to the prenatal and postnatal care, many of the hospitals or many of the health centers, they considered giving prenatal and postnatal care as non-essential. So all these services were postponed during the time of COVID-19. And there was a study which was done in 180 low and middle income countries that identified that there was reduction in the antenatal care about 18%, and this could even increase up to 51.9%. This is not only for antenatal care, even the postnatal also reduced to the same extent. And if you see the number of visits the woman has to go through during the time of delivery, during the time of antenatal period, that also decreased. And women also chose to forego in visits. That is, they hesitated to go to the hospital for antenatal checkup. This was mainly because of family pressure to isolate or personal fear of getting the infection. And if you see Kenya, Uganda and Tanzania, there was a study which was done in which the maternal health workers, they have reported that less number of women were coming to the maternal health clinic to get the service. And at the same time, in West Africa, a different scenario was there. That is, there was a false rumor about the virus, and there was a mistrust that if this maternal health care workers or the midwives was responsible for spreading the infection. So because of that, most of the men, they forbid their wives from getting the services. And there was also reduction in the antenatal care service utilized as clinic reduced hours and number of visitors permitted, and in-person visits during pregnancy also were reduced. And regarding in UK, in order to overcome this situation, what they did is they have provided blood pressure machines, urine analysis sticks to the woman so they can do their own checkup at home. And even telemedicine facility were also provided to the antenatal care as an antenatal care measure. That is, telemedicine, as you all know, that is telecommunication method was used to give service for the woman. That is through video conferencing, text messages, or through phone calls. They were giving all the information to the pregnant woman. But even though these services were given, most of the respondents were worried about the quality of the maternity care. Actually, there is a difference, isn't it? Even if you go directly and if you go communicate through the telecommunication methods, there is some differences there. So that may affect the quality of the maternity care. So that concern was there. Then regarding the healthcare infrastructure, that is how the healthcare facilities were working during the time of pandemic. If you see, the outpatient clinics were temporarily closed during the time of peak COVID-19 situation. And even though if the facilities were remained open, that was with limited healthcare workers, because most of the healthcare workers were shifted to the COVID-19 wards, where so limited healthcare staffs were available to give service to the pregnant woman. So that limited people were overwhelmed, particularly in low and middle income people. And if you see, this pregnant woman who, especially in low and middle income countries, when they came to the hospital, ambulance service or even they were turned away from hospital because most of the hospital were turned into COVID-19 treatment centers. So the pregnant women were not getting adequate services. So as a result, what happened? They had to either deliver at home, and most of the time when they return back to the home, on the way itself street also they had to deliver. So this was the situation too. So in order to mitigate this particular situation, hospital limited the number of people per room and duration of their stay and reduced the postpartum stays. But what happened is that because there are limited number of stays, immediately after delivery the woman was sent home. So this also had a negative impact on the quality of care, because if postnatal period, if some complication arises, there was the care was not received, so that resulted in quality. Then if you see, the maternal and newborn healthcare providers worldwide did not receive training. That was a different situation. That is, even though they were there, they didn't know if the woman is COVID positive, okay, how to give care for such a woman. So that hindered the quality of the care, and most of the time they were not getting, even the women who were there in the hospitals, adequate medications was not there, blood products was not there, because the supply chain also got affected during the time of pandemic. Now, if you see what was a woman's experience on the maternity healthcare service, the first one provided adaptive response to shifting evidence. That is, if we know during the time of pandemic, there was different protocols were coming every day. As new and new researches were done, new protocols were coming, and this what happens, this has affected the providers who were giving care. They were more confused which protocol to be followed, and they were struggling to give the holistic humanistic model. What do you mean by holistic humanistic model? This means that the body and mind are considered as together. That is, emotional support is given to the woman. So this has and at the time of COVID-19, the healthcare workers were struggling to give that particular care to the woman. And if you see, at the same time, because there was no support person was there in the labor room, what happens is that the mistreatment, inadequate, the excessive intervention, unwanted intervention, obstetric violence, all this increased. And there was also this was the situation initially, but as the situation came under control, that is after the healthcare workers started getting the PPEs and testing facilities started evolving, slowly the situation came back to normal, but not as completely. And some hospital, especially in the developed countries, the midwives, in spite of these problems, they tried their level best to give humanized maternity care. And most of the time what happens, the client's rights were negotiated. So these healthcare workers, in some places, they advocated, they tried to protect the client's rights. So this was a response. Then principle of separation and prohibition. This is like separating the, that is, support persons were not allowed inside the labor room. That was the situation, as I already told you. This support person availability inside the labor room, it varied from one nation to another nation, or from one region to another region, because and how long they have to say, or what, under what condition the support person has to say, they all varied from one country to another country, because each country gave different protocols. For example, in Canada, one labor support person was allowed. And if you see Russia, formally restriction against labor support person was there, but still they were making use of the paid contracts. So that helped them to have the support person during the time of delivery. But in case of Italian hospital, you can see that only during the pushing phase, that second stage, during the baby is about to come out, only during that time they allowed the support person. And if you see the United States, only in a few hospitals in United States, what they did is labor support person were permitted from the time labor began, and they were allowed to stay as long as the woman leaves the hospital. But in other hospitals, United States or in other countries, what they did is they ordered the support person to leave immediately after the birth. And because of all this scenario, what happens is the child bearers, that is the mother, she felt isolated, alone, and traumatized. And this ban, what was there on humanized maternity care, that is labor support companion, skin to skin contact, all this ban was put. All this was undone because during the time of as the days passed, there was more pressure from the pregnant women as well as from the providers in order to support the woman's right, especially in Italy and China. So as a result, this ban was removed, and that was the scenario. Next one is separation and prohibition on doulas attending hospital births. So these doulas are the people, they are like they don't have an experience in conducting the delivery, but they act like a guiding person or supportive person at the time of delivery for a pregnant woman, during the pregnancy, during the time of delivery, and immediately after delivery she used to give support and guidance and information to the woman. So this particular doulas, they were either erased or from the labor room or excluded from the labor room because of the pressure from the medical bureaucracies. And many of the times they already knew that being doula with the laboring woman, it had a positive outcome. In spite of knowing that also, there was strong pressure from many of the medical institutions to neglect their service and remove them from the labor room. And in many countries, even in spite of this scenario, the doulas struggle to get access to the labor room to support their clients. And in United States, you can see that there's doulas fought to regain access to the hospitals. And because this was not possible, what they did is they started teaching the clients, partners, critical doula skills. And in South Africa, you can see that because there was travel restriction and only the healthcare workers were allowed to move around. And so during that time, in order to get access to the clients, the doulas, they try to get the doula certificate, or they try to get special permission to get, so to give service to the clients. And in some places, they did phone calls and video chatting regarding antenatal and intracranial care, so that the curvis disruption can be prevented. Then separation of mother and baby. This was another situation which came about during the time of pandemic. That is, there was principle of separation and prohibition. That is, the mother and the newborn were forced to separate from each other during the time of pandemic. If you see in United States, 1 in 5 hospitals, they discouraged skin to skin contact at the early summer in 2020. And if you see in Russia, all mothers were denied contact with the baby at least for 2 weeks immediately after delivery. And even though early recommendation in WHO has told that if the woman is positive, the newborn has to be separated from the mother. But when they saw that this is having some bad effect on the baby, the CDC and AAP recommended that mothers and newborns should be kept together, even if the mother is positive, as long as the mother is not critically ill. And another interesting fact is that if you see in New Zealand, in spite of this particular recommendation was done initially that the mother and baby has to be separated, they stress that the skin to skin contact and breastfeeding has to be continued. And while hospital first struggled, they found sufficient PPE for their providers. And sorry, next one is personal protective equipments and testing. As you all know that initially there was shortage of personal protective equipment, and though testing was there to identify whether the disease has infected. So during that time, what happens is that many of the healthcare providers, there was shortage of this personal protective equipments and community-based. And initially, when the hospital started getting these PPEs, first they were the healthcare providers who were giving care for the Covid19 patient, they were receiving these PPEs, but the birth workers or the community-based providers, they were not getting adequate PPEs, but they received these PPEs and testing facility only at the end. So till then, they were struggling with the limited resources what they had. And at the same time, during this pandemic situation, they had, especially these community-based midwives, they had to go to the community where without any sufficient PPEs, and with during that time there was community spread with asymptomatic cases also. So they had to face all these things. And if you see regarding the pregnant women, they were forced to wear masks. As you all know, during the second stage of labor, the ability to breathe heavily, there will be a difficulty in breathing, isn't it? And their ability to breathe heavily will be compromised. And on top of that, wearing mask was a difficult scenario. And another thing is that because the midwives were coming to the community with inadequate PPEs, they were stereotyped as dirty, unsanitary, uneducated, ill-equipped, also date back centuries. So like that, stereotyping was done on the midwives. So, and especially if the midwife is of a particular ethnicity or in a particular race, or especially black midwives, so they were had a tough time going to the community to give services. And at the same time, they were also not receiving adequate government support. Official status was also not given to them. So this also resulted in making them vulnerable to in this medical crisis. And midwives have been neglected with requests for community-based care. Without any, the midwives were going into the community without any PPEs, and they were forced to give service to the people in the community, and the government were not giving any compensation or recognition or reward for this increased. And during that time, even the client or number of client were also more, because most of the women were preferring to have delivery at home. So this has all resulted in extra workload on the community-based midwives. And next is the rise in community births. As you can see, there was an increase in the rate of community birth, as I already told you, because of the fear of getting the infection. Many of the women, they preferred having birth in the home or in the freestanding birth centers. So as a result, what happens if any complication arises, then there was a need for women to be transferred to the hospital next. Then community midwives have been struggling to fully meet the increasing demand of the service. So the demand was more, but there was only limited community midwives was there. And because of this, what happens, their workload on the midwives was more. There was a division came between the hospital based and community maternity care, and as a result you can see the fear and the threatened medical establishment. There was because of the rise in community births, and they were doubtful about the power of the midwives in giving care for the woman during the time of delivery. Next one is turning to traditional midwives during COVID-19. So as the community births increased, automatically the women were going into to the help of the traditional midwives to get delivered. If you see the a study which was done in Kenya, Pakistan, and Guatemala, it is a place in Central America. They have identified that there was increase in the community births. So before COVID-19, the comadronas means traditional midwives were allowed to accompany their clients in the hospital, even to receive the baby. So the traditional midwives were allowed inside the hospital. But the situation became different immediately after the pandemic started. They were not allowed inside the hospitals. And if you see, the traditional midwives were restricted from attending the births, especially in Pakistan and Kenya, even before the pandemic has started. And they also encouraged, especially in Kenya and Pakistan, they encouraged government, that is the government push that all the women in that particular country, they have to have facility birth so what happened, these traditional midwives were given less importance, and they were not given adequate training, or that was the scenario. Then in spite of all these things, the midwives, they continue to give the service to the rural as well as the underserved communities. And if you see, even if the additional clients were coming to these midwives for seeking their help, they were attending to those clients also. And if you see the statistics, around 900 people, skilled midwives needed to reach full coverage of sexual and maternal and newborn and adolescent health needs. That is, there is a shortage of around 900,000 people, but still what happens, and this in order to reach full this shortage is there also. Their training and investment until 2030, if they do only, they can reach at least 80% of that. But by the time it reaches 2030, the gap between the need may get again widened. Next one is fear and stresses for childbirth. That is, the pregnant woman was experiencing lot of fear and stresses during the time of delivery. What is the reason? So one is that fear of viral contagion, that is getting infected. Then fear of not allowing the support person to be with them. They had to choose between the partner or the doula. Any one person they only allowed at the time of delivery, and the fear of getting separated from their baby, and isolation procedures, especially during the pregnancy, labor, and postpartum period. So all this fear contributed to stale labor, that is prolonged labor was there, postpartum births were there, miscarriage, stillbirth, low birth weight, preterm babies, all this increased. And the childbearers were left to get struggling to get access during the time of pandemic. This also increased their anxiety and stress. And as well as in the hospitals, you can see they gave importance to technocratic model of birth. That is, they were considering the woman only as a machine. No emotional support was given, because they were maintaining only limited contact with the woman during the time of delivery. They ignored most of the needs of the woman during the time of delivery. So they were ignoring the woman's right. And there was also surge in infant formula. As I told you, the baby and the mother was separated. At least for during that time, what happens, infant formula was fed. So the infant formula use also increased shortly after birth. So this also increased the stress among the women. And another thing what contributed to the racism and hostility, minority population, those who were there coming for delivery, they had to undergo obstetric violence. So this also increased the stress. Next condition is racism and inequality in maternity care. As we all know, there is, from the time period existed, there was some kind of inequality between wealthy and poor person. That particular inequality increased during the time of COVID-19. And even if the midwives, nurses, doulas, we all know that most of them are women. So because they are women, their works were considered as devalued. And COVID-19 pandemic had a severe and disparate effect on the birth workers and women of color. So the birth workers or the women who were of black color, they were treated very badly, and there was more chances of negligence during the time of delivery. Obstetric violence was there, or the birth workers, black birth workers also experienced violence from the society. So that was the scenario. And in United States, the pregnancy-related mortality, that was more seen in the black woman. If you compare it with a non-Hispanic white woman, non-Hispanic means a Middle East woman, African woman who are there in the USA. So if you compare it with them, it was around 3 times. And if you compare it with the Hispanic woman, that is Spanish woman, Mexican woman who was staying in United States, if you compare it with them, it was 3 times more for the black woman. In Canada, there was a gap in access to the certain services, especially in the rural areas or First Nation, because of the long distance and limited availability of transport. So next one is providers' mistrust of government and maternity care services. So because of certain decisions the government and the maternity care system was taking, the healthcare providers automatically lost trust in the government. So what are that? One is broad rules preventing partners in the labor room. As you all know, this is like violating the woman's right. So they had to adopt to this because of the pressure from the government. Another is government opposition to mask wearing. Initially, when the pandemic hit the world, the government had some kind of opposition from wearing the mask. So that also contributed to developing mistrust towards the government. Another is hospital there was a confusing of cascading as well as contradictory rules were there regarding the how long the hospital quarantine has to be there, what type of infection control measures has to be done, and regarding the transportation of the mother to another hospital against their will. All these things were happening. So all these things the providers had to do because of the pressure from the higher authority. Some providers or the hospital adopted accepting informal pays. That is, if the government might have told there is no support person allowed, but what the hospital has done is they started taking the payment so that they can allow the support person to be with the mother unofficially. So this was the scenario. Another thing is that the women who were coming to the maternity care services, because of the mistrust on the government or on the healthcare system, they were not they were disguising their COVID-19 symptoms. And in some healthcare facility, you can see that the maternal death might have taken place because of some other reason, but they misrepresented it as COVID-19 deaths. And even the midwives in some places, they were not given adequate payment, and their needs were not ignored most of the time by the government. So all this started developing mistrust in the government by the providers. And you can see even the clients were also sent home immediately after the delivery. As I already told you, that was the condition. So even if they develop some serious medical condition, instead of shifting them to emergency room, they were shifted to their homes. Next one is telehealth and virtual ethnography. So this was done in order to continue the service to the woman during the time of pandemic. So during the telehealth, using the telehealth, what the obstetrician midwives and dollars, they resorted to this telehealth to give early prenatal visits. So most of the visits were done through this telehealth. And some women during the time of this visit through the telehealth, what they did is they started teaching the woman some of the minor procedures like checking the vital signs, how to take care of their health at home. So regarding, they were empowering the woman with these skills. And at the same time, you can see in some places, they were combining the visit, one with in-person appointment and with the telehealth. So both were taking place in some places. So this will limit the number of direct contact with the health person. And in hospital also, they started using this text messaging system between the department heads, so they can communicate regarding different strategies, different protocols, as well as schedules, instead of coming in direct contact with each other. Then they also started an Instagram account to develop. This pregnant woman during the time of pandemic, they were developing more stress and experiencing during the time. So in order to for that to help them, what they did is they started an Instagram account through which they can communicate freely with the hospital staff. So through this, they were continuously in contact 24/7. They were continuously in contact with the pregnant woman. They were helping the woman in all the ways possible through this. So this has helped a lot. But in spite of this telehealth, there was also some disadvantage to telehealth also. Already we know that a lot of technology is coming to the hospital. So this has added up more technology into the health service. And most of the time what happens is getting access to the internet and some of the sophisticated smart devices, it is very difficult to get access to the poor people, or they may not be able to afford it. So that has also resulted in some of the getting underprivileged with that. Another thing is that the providers itself used to shut down or disable the device in times when it is very badly needed, especially during labor and delivery. So this was taking place. Then another is virtual ethnography. As you know, ethnography is a study of a particular culture in a society. So these ethnographers has to go to a community, stay there and learn their culture, behavior, language, and all those things. So during the time of pandemic, because the travel bans were there, they were not able to reach to that particular field and do their studies. So instead of that, what they did is they started using online researches they were doing using the survey, questionnaire, interview method. So this has also resulted in getting excellent results. And another interesting thing is that they started a community-based shelter-in-place research. That is, being in their house itself, they started a group through which it helped the birth workers, that is the midwives, to form a circle of midwives through which they used to share the strategies which can help the cope up with the pandemic. And you know that racism, how to overcome the racism, or how to protect the rights of the woman. So regarding all those things, they used to share information. So this also had a positive impact. Another is maternal and newborn rights during a pandemic. And there was a lot of many of the violation of the rights of the mother and newborn has taken place during the time of pandemic. I can give you some example is enforced separation of mother and newborn. As I already told you, they were forced to get separated from each other, and the mother is laboring alone without partners or without support person, and lack of informed some consent, especially during some rushed procedures. Disrespectful or abusive care was given to the and it was difficult to track also during the time of pandemic this violation, because no support person was there. And even after removing this ban also, still some of the hospitals were following this principle of separation, especially giving the reason for COVID-19 as an excuse. So though that was the scenario, but in some countries they had a positive impact also, like in New Zealand. You can see even in the midst of pandemic also, the midwives there started honoring the rights of the woman. They tried to preserve the rights. And if you see in USA and Mexico, the mother's rights to be with their newborn and family and partners were preserved. And in some other parts, there was, especially where the black birth workers were working, they developed a virtual sharing circle using some telecommunication device. So through that, they were finding their community, and they were discussing regarding how to self-advocate, especially the woman right of the dollar care and rooming in, how to protect the rights of the woman, especially the black woman. So regarding all those things, they used to discuss. And then next is the need for full integration of community birth providers. As you all know, this support, the service provided by the community birth providers were neglected during the time of delivery, during the time of pandemic. And either they were left with little or no government support. So from the provider side, if you see, no insurance were given, and they were not backed up by any physicians. They had to work freely. Even if the complication arises, they could not refer them to some referral system. And even if they come with the patient to the hospital, even in some emergency or complication, they were not given adequate respect. So that was the treatment. But if you have to overcome this situation, one main thing what we have to do is we have to treat them well upon arrival, and we have to encourage the community midwives to stay in the hospital and provide support and continuity of care to their clients. And even if you see the scenario in USA, their best practice guidelines were developed, but the interesting fact is that community midwives were trying to follow them. And if you see in some of the major hospitals in USA, they ignored these practices. So that is the power of these community birth providers. And so it is very essential that we have to legalize and license these community birth providers, and we have to give adequate insurance services, respect their service, and compensate for their service. If you do all these things, then only the people who are in the remote areas, they will get adequate service from the. So that is regarding the integration of community birth providers. Next, we will see what are the recommendations. Now we know what is the scenario of maternal health service in the world. So based upon this, what recommendations can be given? One is that prioritize. We have to see that maternal health service is given priority. You have to consider that it is an essential service and increase the resources. We have to see that whenever there is supply shortage is there, we have to replenish the resources what is required in these areas, and optimize the service delivery settings. That is, hospitals should have adequate facilities with adequate staff. And if you are not able to give direct inpatient service, at least through telemedicine, the continuity of service has to be maintained, and adequate infrastructure has to be maintained. Healthcare workers should be there who has to be skill mixed, and we have to ensure the commodity security for uninterrupted supplies, and adequate financing should be done, so that further research will be done in this area, so that we will be more strengthened to give quality care to the patient during this pandemic. And you also have to see that this service should remain open and functioning whenever the woman requires. And also adequate transport facilities should be maintained, especially between the facilities, and adequate PPEs for healthcare workers. Emotional support has to be given to the healthcare workers. Protection for pregnant women attending routine services, this has to be done. And And we also have to ensure that pregnant women know that they should still attend the antenatal care. Even if the pandemic is there, still they have to get the service what is required so that their health will be optimal. So this is the some of the recommendation what we can give in order to improve the maternal health service. So we have come to the end of the section. So I would like to focus few things during this pandemic, that is pandemic as a touchstone and a pivotal or transformational moment. That means we all know that during the time of pandemic, there was lot of disparities, a lot of problems were there for the were there for the woman, which was previously also there. But during the time of pandemic, this all things came to the light. We came to know more that these things are happening around us. So I think that if you this pandemic can be considered as that is going to get a positive change in our society, especially if the researchers, policy workers, as well as midwives, if they stress to give humanistic, emotional care for the woman, we can have a better society in the future with the quality care being received by the woman in maternity care. So this is all about the impact of COVID-19 on maternal healthcare services and women's experience. Thank you.
Okay, thank you, ma'am. Your wonderful presentation. So we have discussed about impact of COVID-19 affecting the maternal health services. So during COVID-19,
Yes.
we have seen many this one mother were suffering with preterm delivery, stillbirth, low birth weight baby, premature baby, and also there is no proper ANC services. Then some mother may
Yes.
undergone depression, anxiety, and maybe fear about transmission of infection to their children. And that time also there is a limited healthcare services because all most of the hospital filled with COVID-19 patient. And some of the African country, the mothers were going traditional birth attendance. So some of the mother they have started telehealth and virtual ethnography. So these are the mother have faced many challenges, especially ANC mother during COVID-19 pandemic. So thank you one and all. Thank you, ma'am.
Thank you. Thank you. Thank you.
Hello, sir. Hello, sir. Okay, ma'am. Thank you.
Okay. Okay. Bye. Thank you.
Okay.